All right. Good morning, everyone. As Dr. Pybro said, I'm Dr. Megan Rogers McCormick. I'll be moderating this first session, and it's my pleasure to introduce our first session of the 2023 AOCA Annual Conventions. Today and this morning, we will be joined by Drs. Agnes Hunyadi. Did I say that right? Okay. Dane Grenda and Robert Molnar. Dr. Hunyadi is a staff anesthesiologist at Seattle Children's Hospital and associate professor of anesthesiology at University of Washington. She has longstanding clinical and academic interest in pediatric airway management and is the lead anesthesiologist for the otolaryngology service line at her institution. Dr. Hunyadi is also the chair of the Pediatric Difficult Intubation Research Collaborative. Today she'll be talking about pediatric critical airways. So please join me in welcoming Dr. Hunyadi.
Good morning, and thank you for the introduction. So this is my topic. I have disclosures to make, but I won't be talking about any of the products. These are my goals and objectives as listed in the program. And the outline of my talk is I will examine the definition of critical airway, pediatric critical airway, and then I will present three pretty classic critical airway scenario. And of course, pediatric critical airway scenarios are infinite and unique, but there are certain patterns, and it is my hope that through these three classic ones, we can examine the commonalities. And then I will talk about approaches to the management, including an interdisciplinary critical airway team. So the distinction between difficult and critical airway is somewhat problematic. We are all familiar with the definition of difficult airway in anesthesia. However, I need to point out that in the pediatric literature, difficult intubation is often referred to as more than 3 attempts at intubation. Furthermore, critical airway is sometimes defined as airway management occurring outside of the operating room and where ventilation and oxygenation is impaired. Sometimes it's referred to as physiologically difficult airway. And I would put into opposition with the difficult airway, which happens in the OR, where the situation is usually controlled, the tools are available, and the patient is optimized. I would like to argue that in my context, such distinction is unnecessary or problematic, since my patient population, neonates and infants, they have very high oxygen compared to adults. They have high oxygen consumption and high closing capacity, which means that a simple difficult airway scenario can easily deteriorate into a critical airway scenario and result in sort of a cycle of cycling in and out of critical airway scenarios. So in my own institution, critical airway is simply defined as a scenario which is often actually predictable, where ENT presence is desired or necessary. Going through the next 3 scenarios, I hope that they would illustrate that in the pediatric population, we really need to shift our focus from the question how we will intubate this child to how we will maintain and augment oxygenation through the scenario. So the first one is pretty classic, sudden onset of stridor in an infant. And for color, I threw in cold symptoms for the last 3 days. Stridor is a sign of laryngeal or extrathoracic tracheal pathology. And conversely, extrathoracic tracheal pathologies present with stridor. There is a long laundry list of causes and etiologies that vary according to age and level. But most important for us, especially in this scenario, is airway foreign body aspiration. They are common, they are relevant to us, they can come to the OR anywhere. They affect predominantly children, and they result in fatal injuries, hundreds of fatal injuries annually. Furthermore, the diagnosis can be problematic, and really the only way one can rule it out is through bronchoscopy. Therefore, we might all encounter them at some point. The types of foreign body varies depending on the culture and the geographical location. In the Western culture, most of them are actually organic materials, most commonly peanuts. The problem with peanut is that the external diameter of the peanut or peanut-sized object, shall it be bead or toy, is actually the same as roughly the same as the internal diameter of a pediatric or an infant airway. And as you can see on the above video, breathing through a very small hole can be difficult. Nevertheless, these children are surprisingly able to maintain oxygenation for a good amount of time. However, positive pressure ventilation can be extremely difficult, if not impossible, and the object can present a ball valve effect and result in a crisis scenario. Therefore, preservation of spontaneous ventilation is mandatory. There is a differential diagnosis of sudden onset stridor or stridor, although the most common is actually laryngomalacia, or at least for the chronic pediatric stridor, whereby the epiglottis and the arytenoid cartilages fall into the glottis with every single inspiration. However, they are usually not sudden in onset. They are usually present from birth, but they can be occasionally quite severe, causing difficulties with positive pressure ventilation. Another very common one is subglottic stenosis, can be acquired or congenital, and again, kids can be very resilient. They are often able to maintain oxygenation through a very small hole, but positive pressure ventilation can be very problematic, resulting in gastric insufflation and a crisis scenario. Furthermore, subglottic stenosis can be a little bit like a box of chocolates. You don't know what's underneath. This can be just a small membrane, thin membrane, or it can be a tracheal sleeve or a subglottic stenosis affecting several segments. Again, maintenance of spontaneous ventilation is mandatory until we figure out what's below it. Another classic scenario is the infant or neonate with Robin sequence. But it could be any other child any other neonate that has a mass, making face mask ventilation difficult and intubation difficult as well. So this particular neonate was here in the OR a couple of days ago and had a cannot ventilate, cannot intubate scenario that resulted in cardiac arrest, and now he's coming back for a second try for mandibular destruction osteotomy. How common is this scenario? Well, we don't really know. We don't have good data. However, I would like to draw attention to a couple of newer studies that started. They are large-scale studies that look at incidence of difficult tracheal intubation, and with that we do get some glimpse into possibly how common the difficult to intubate, difficult to ventilate, or impossible to intubate, impossible to ventilate scenario could be. One is the Nectarine study, neonate and children audit of anesthesia practice in Europe. The other one is pediatric study, national emergency airway registry for neonates, and an anesthesia research collaboration is the pediatric difficult intubation registry. What we learned from these large-scale studies is that hypoxemia is very common in young children that are difficult to intubate, and hypoxemia very often causes cardiac arrest. In fact, all cardiac arrests in the PDIR were preceded by hypoxemia. And we also know that infants and neonates are especially vulnerable. In the PDIR, almost 50% of children with complications were weighed less than 10 kilograms. That means they were infants. What's the problem with the cannot ventilate, cannot intubate situation in a neonate? Well, the rescue is difficult. Supraglottic airways don't always sit well. In the PDIR, about 17% of the time when the placement was attempted, it resulted in poor ventilation, and in 2% of the time it was impossible to place. We do know that ECMO cannulation, which is in the algorithm, takes time. Anybody who's been involved knows that it cannot be even with the best setup and best readiness, it's not appropriate for rescue. The last one I was involved with took 40 minutes by a cardiac surgeon. We also know that emergency front of neck airway is problematic in a neonate. We are trained to do cricothyroidotomy in the CVCI scenario. But a cric is problematic in an infant because, first of all, the cricothyroid membrane is incredibly small, definitely does not accommodate an ET tube. The plane of the cricothyroid membrane, because of the funnel shape of the infant glottis, is not parallel to the plane of the trachea. Furthermore, the hyoid bone often overlies the cricothyroid membrane, which makes it impossible to palpate, let alone the adipose tissue above the cricothyroid membrane and the hyoid bone. In one study, under very controlled circumstances, 30% of anesthesiologists actually fail to accurately pinpoint the cricothyroid membrane in children. We should explore alternatives to cricothyroidotomy in children and infants. There are of course, there is emergency tracheotomy, which we are not trained in. Our best approach should be avoiding these scenarios at all cost. Switching gears, case scenario number 3 is the classic anterior mediastinal mass or intrathoracic airway obstruction. We've all seen them, at least I think. Classic symptoms are cough, dyspnea, dysphagia, orthopnea, most importantly, and often SVC syndrome. X-ray is typical widened cardiac silhouette. Half of them will come to a pediatric institution because half of them affects children. half of the masses are malignant, most commonly lymphoma or leukemia, but other tumors like germ cell tumor are there too. The presentation is usually a very rapid worsening of intrathoracic airway obstruction and sometimes SVC syndrome. The problem is that for the correct diagnosis, a tissue sample is mandatory, and an empiric treatment is not recommended because it will obscure the diagnosis. The good thing is that fine needle biopsy of the mass or biopsying an extrathoracic site is usually also results in good diagnosis, occasionally even sampling of pleural fluid. So chest CT is mandatory, and what we mostly look at is the degree of tracheal compression. And based on the tracheal compression and the presence of cardiovascular symptoms, these cases can be classified or risk stratified. High risk scenarios are where the tracheal, the TCA, the tracheal cross-sectional area compared to the predicted is less than 50%, or if it's more than 50% and there is bronchial compression, that is also that scenario is also bumped up to the high risk category. In that category, general anesthetic is usually not advised or carries very high risk. And we all know how abolishment of spontaneous ventilation leads to cardiovascular or airway followed by cardiovascular collapse through the taking away the stenting effect of negative intrathoracic pressure. Of course, there are other intrathoracic airway obstructions, but they rarely present such in such a dramatic way as anterior mediastinal mass, maybe with the exception of tracheomalacic spells or BPD spells. However, the management of those is a little bit different. Extrathoracic stridor, or rather intrathoracic stridor. So what are the commonalities in these three scenarios? Well, the risk of cannot ventilate, cannot intubate. Why is it? Oh, okay. All right. So thank you. So what do these three scenarios have in common? Well, the cannot ventilate, cannot oxygenate situation can evolve very rapidly, and the situation can deteriorate into a crisis situation fast. The intubation might or will not work, or might not be possible. Front of neck airway, the ultimate step in the algorithm, might also not be possible or might not solve the problem. A definitive airway may take a while, and therefore, strategies to maintain oxygenation to avoid or resolve the crisis are very similar, which is that the focus should be on prevention of this scenario and on the oxygenation, on maintenance and augmentation of oxygenation. So the main decisions to make are is whether it's safe to anesthetize or sedate children, and even in the pediatric population, awake airway management should not be ruled out, and then whether abolishment of spontaneous ventilation is wise or not, and if despite all efforts, spontaneous ventilation stops, can we maintain oxygenation through an apneic method. So how can we maintain oxygenation? Well, there are many ways. The modified nasopharyngeal airway is often used. Low flow or high flow nasal cannula. The only difference between the two is that, well, in my patient population, because we can really increase the flows in the low flow with the low flow nasal cannula to the desired 2 liter per kilogram per minute too, but the high flow is humidified, which is much more pleasant for and warmed, which is much more pleasant for the patient than without that. Of course, we can use intubating LMAs that we can ventilate and oxygenate through during intubation attempts. And finally, if all else fails, apneic oxygenation should be considered. We know that infants, ASA1 infants with perfect pre-oxygenation can maintain saturations above 90% for about 96 seconds. In premature neonates, this is about 22 seconds. And we know that with high flow nasal cannula administered at 2 liter per kilogram per minute, apnea times can be doubled, which can be a lot in my context. Then the next question is, where should the airway be managed and who should be managing the airway? So we know that out of OR airway management results in worse outcome. We know that from the NAP4 trial, and we know that from the NAP4 audit and from the PDIR. But transport is risky and it takes time. So the question is there, are we able to transport the OR to the patient instead? And that thought gave rise to the development of various rapid response teams, including airway response team, difficult airway response teams, pediatric difficult airway response team, or critical airway response teams. And you're probably familiar with them. You probably have a difficult airway response team in your adult institution. And Johns Hopkins is really leading the way in describing the history and elements of such response teams. Members of such a team, of course, depends on what level of alertness you want. Difficult airway teams always include anesthesiologists, critical airway teams, ENTs, and ECPRs, obviously thoracic or general surgeons. It's important to have a very reliable communication method in activating such a team. There should be some redundancy. The call should go through the same dispatcher as any other rapid response calls, like code blue. And the redundancy could mean overhead plus pager, pager plus phone, overhead plus phone, etc. The activation should happen through agreed upon triggers. In my institution, it's a known difficult airway or known critical airway, for which there is usually a bedside sign, or certain diagnosis prompts such activation. Diagnosis coupled with respiratory distress, and sometimes it's a new finding. Equipment, very important. They should be uniform throughout the hospital. They should be stored close to likely venues. For example, we store one at the ED, we store one at the PICU, and of course several in our ORs. Each team should their preferred equipment, and there should be some redundancy because we know these situations can be chaotic. And equipment can be misplaced and contaminated. And of course, it's important to have ownership. Somebody has to have ownership and stewardship over the stocking of these carts. They are usually carried in carts. Teamwork, very important, especially knowing what the roles are and how to shift these roles. The team lead role should often shift. For example, from if it's in the OR, the attending anesthesiologist that's managing the airway will shift the role of resuscitation to the board runners so that they can focus on the airway management, or in the PICU initial airway management team will shift that role to the arriving response team, and they would manage the code situation. Huddle, however short that is important, so that everybody can have a shared mental model as to what order things will, the plan should be executed, and who should be the one taking the first pass on airway management, because your first pass is always the best pass. And most importantly, there should be a multidisciplinary airway safety committee, because the goals and needs of such airway response team need to be clearly defined and well articulated towards hospital leadership. This is a costly effort, funds are needed, and collaboration with other committees, including the Code Blue committee, is needed. Of course, dissemination of their work, policy making, is super important, and maintenance and training falls under their list of tasks. In my institution, they, as I mentioned, they are very costly and time-consuming to build. So the question begs whether these teams actually make a difference in outcomes. Most of the literature comes out from Johns Hopkins, and they showed that over 10 years, in adult airway management, over 10 years, there were no airway-related deaths or sentinel events or malpractice claims for adult patients, and they were able to maintain these results over a long period of time. In another study, they report a reduction in the number of emergency surgical airway procedures that were performed by anesthesia. And in the pediatric realm, pediatric difficult airway consult service resulted in decreased emergency difficult airway calls. In another, Cincinnati reported a more rapid response time and elimination of simulated patient death. My institution's journey was similar. Recently we just measured the intubation attempts over the years, and the thought behind that is that we know from the PDIR and other studies that complications of difficult airway management go up linearly with the number of intubation attempts, and that's why limiting attempts is important. And we saw that despite of an increasing number of CPR events, we were able to reduce intubation attempts. And we went through many iterations, and the function of our critical airway team evolved over the years, and many measures were done in a stepwise fashion. But I just want to point out 3 of them that we felt made the biggest impact. And the first one was obviously the creation of the multidisciplinary airway committee, which ended up involving more and more services, including the ones that would trigger such calls. Like the NICU, for example. And then another very important event was the making the policy that anesthesia coaching presence should be mandatory for all intubations. And that was a huge cultural shift in our PICUs and especially in the NICUs. But eventually eventually it was accepted and integrated into practice. And then the newest addition was the renaming and reformatting the team and calling it the critical airway team and involving ENT from the get-go into these often predictable events. So in conclusion, pediatric difficult airway scenarios and pediatric critical airway scenarios can evolve very rapidly and escalate in crisis situations. So understanding the physiology and focusing on oxygenation instead of intubation can buy time and perhaps enough time to pool expertise to resolve the situation or prevent such crisis scenarios. And a well-functioning multidisciplinary airway team might improve critical airway management outcomes in children. And I think that was it. Thank you very much.
Thank you so much, Dr. Hunyadi. Our next speaker is Dr. Dane Grenda. So Dr. Grenda is the current Director of Anesthesiology for Otolaryngology and Oral Maxillofacial Surgery at Thomas Jefferson University Hospital, affiliated with Sidney Kimmel Medical College in Philadelphia. His research interests include novel techniques for non-invasive oxygenation and standardization of difficult airway management. Today he'll be speaking on the role of nasal high flow for airway management. Please join me in welcoming Dr. Grenda.
So good morning, everyone. And since I presented in Chicago, there's a slight change. There's a big T under the title now. So I'm at Temple University Hospital and Fox Chase. That's quite all right. Thank you, everyone, for being here this morning, particularly those that came in late last night, such as myself. And a special thanks to Suzanne Huffnagel for the invitation to speak this weekend. And this is a topic that I guess some people express some interest in the Chicago meeting. Something that I'm very interested in. And just a little bit about my background is that I did a fellowship in head and neck anesthesia, difficult airway, so very passionate about airway management. And I hope you guys, you all find this as interesting of a topic as I do. So the title of my talk is Thrive On, the role of nasal high flow for airway management. And the concept of thrive is really the anesthetic application of high flow nasal oxygenation. And I don't have any conflict of interest to disclose. And briefly, I'll discuss the different components of high flow, the important mechanisms and physiologic effects, the potential uses, contraindications and potential risks, and applications in practice, which are probably the more interesting portion of that, and of course future directions. So briefly, any guesses what high flow? So it was developed probably even before the early 2000s, but at initial application, what patient population do you think it was utilized in? Anybody? It goes along with the first talk, so pediatrics. And it was utilized in the pediatric ICUs. And since that point in time, there's been expanding interest, and probably not until about 2015 was it studied in adult populations beyond the ICU. So there's been continued interest around this, and one of the first publications that kind of expanded on its uses, how to use it in different components, was this, I remember reading this in residency, was the Anesthesia Patient Safety Foundation article discussing its use. And it was an article written by international collaborators, so by that point in time it was a relatively internationally known concept, and it was one of the first places that they kind of coined the term THRIVE, so transnasal humidified rapid insufflation ventilatory exchange. And briefly, I just want to touch on the different components. It's relatively intuitive, but you have a high pressure oxygen air supply, of course, and some systems require a blender, a flow meter, oftentimes exceeds 70 liters per minute, some even up to 100 liters per minute, a humidifier, wide bore tubing, and then a heated wire circuit. And this is a description. This is an example of the OptiFlow, which is what we currently use at my institution. And just to point out the key components again: flow meter, a humidifier that's just typically filled with normal saline, wide bore tubing, and the heater wires circuit. Not unusual to see these in the ICUs on patients. And again, this is just an example of the wide bore nasal cannula. And the basic setup for this is, again, you got your patient in the room, cannula on the patient, you can pre-oxygenate. Typically, patients tolerate somewhere between 20 and 40 liters per minute. I usually do 30 to 40 liters per minute. And the thought or the goal would be to reduce entrained air. And once you have a critically ill patient or a patient in respiratory distress or an apneic patient, you can increase your flows to up to 70 liters per minute. And again, the thought, the goal, is to reduce entrained air. So increasing your flow reduces that would exceed the patient's inspiratory flow rate, would reduce the entrained, or the amount of entrained room air. And switching gears a little bit, we're going to talk about the physiologic effects, kind of answering the question of how this works, why we should use it. And the underlying concepts of thrive or high flow stems back actually to the late 19th century in an article. I really had to go digging for this one, but it was an article written in the Journal of Physiology that kind of outlined this concept of apneic oxygenation. They described it as respiration without respiratory movement. And the proposed idea that the combination of cardiogenic oscillations with an external force that created turbulent flow, they could actually provide some degree of gas exchange. And we think back to residency, medical school, and even in anesthesia training, this concept is revisited frequently on the in-training exams about dead space. More specifically, physiologic dead space, which, depending on resource that you read, it probably ranges somewhere between 2 to 4 mLs per kg, and it's made up of the sum of anatomic and alveolar dead space. And thrive, or high flow, actually reduces anatomic dead space. It does this by providing more efficient ventilation through creation of highly turbulent flow vortices, which aids in CO2 clearance. It provides some degree of CPAP. It's always a big question: is this an adjunct, or does this take the place of CPAP? And no, not at all. But it provides, it's a low pressure system. It provides somewhere along the lines of 3 to 5 millimeters of water pressure, which is sometimes just enough to provide or keep the airways open. It assists in the process of oxygen diffusion in the alveoli, and it also improves thoracoabdominal synchrony. And in addition, it reduces respiratory rate, which in doing so decreases the work of breathing, which, as you can imagine, has relatively significant effects in our critically ill population. It provides humidification, so it enhances mucus clearance and improved ciliary function, which can therefore reduce the risk of atelectasis. It reduces airway resistance, and we think back to Purcell's law, which again is regularly tested on our anesthesia exams. By increasing flow rate, you therefore reduce airway resistance. And the potential uses, it works very well as a pre-oxygenation modality for induction of anesthesia. It provides, it's a great source of oxygenation during awake tracheal intubation, and we'll dive into these a little bit further. Oxygenation during intubation following induction, as well for reducing the work of breathing during general anesthesia or under MAC. And as well as a great thing to have on board when you're preparing to extubate a patient, particularly in the ICU setting. I think it's important to note some of the relative contraindications and absolute contraindications. So nasal obstruction, again, these are relatively intuitive: disrupted airway, inability to tolerate hypercarbia if prolonged periods of time, contraindications to high oxygen concentrations, such as if you're lasering in the airway and your risk of airway fire is relatively high. Need for a laser, as I mentioned, and infection, and absolute contraindication, a complete nasal obstruction, active epistaxis, skull-base fractures would probably be a very poor decision to utilize it, significant pneumothorax, all right? And now the more exciting portion of this, is how it's being studied today, how it's being applied to our current guidelines, how it's being studied. And again, we're going to talk about pre-oxygenation, physiologic difficult airway, its use in awake tracheal intubation, and I think that goes hand in hand with topicalization. We'll talk about that. It's used for surgical laryngoscopy, as well as for extubation. And one of the first papers that laid the kind of groundwork for the use of Thrive, particularly with regards to pre-oxygenation, was back in 2015, as I had mentioned. And it was an article published in Anesthesia in 2020, and it gained a lot of, 2015, and it gained a lot of traction, a lot of excitement, particularly with some of my colleagues. And I wasn't even in residency at that point in time; I was still in medical school. And it was a small study, small cohort of patients that looked at data for 25 patients with known difficult airway pathology that were going for a variety of procedures, and the goal was, again, to the patients were going to have different airway modalities, so LMA, jet ventilation, endotracheal intubation, and they wanted to see if providing high flow nasal oxygen in this setting, if they could delay the apnea time. So they got the patients into the room, they pre-oxygenated them, they induced general anesthesia, they confirmed maskability being the safety net, and then they stopped, and they watched, and they waited. And you could imagine after 10 or 15 minutes, you either just get sick of waiting, or you're waiting for something very exciting to happen. But what they found was the median apnea time was approximately 17 minutes. There was 2 outliers in this. 2 patients required interventions at 5 and 7 minutes, and their cutoff time was really 92%, so an SpO2 at 92%. Not a single patient in this study desaturated less than 90%. And again, as you can imagine, it has a relatively profound effect, particularly in patients with known difficult airways. Moving forward, it is a great pre-oxygenation tool and supplemental oxygenation tool for patients undergoing awake endotracheal intubations. We do these relatively frequently at my current institution. I wish I had Thrive, but I use this relatively frequently when I was in fellowship. And now it's being incorporated into some of our national or international guidelines. And those that are familiar with the 3 big airway societies, so there's Difficult Airway Society, which is this one. There's Society of Airway Management. There's Society of Head and Neck Anesthesia. Why there's 3, I'm not really quite sure. But there's a lot of overlap with members. And I suspect at some point in time, Society of Airway Management and Society of Head and Neck Anesthesia will combine. But nonetheless, they propose their guidelines based on UK-based. It's a UK-based group, but a 10-member guideline, and they sent out surveys to 43 international experts. And through their analysis, and based on the current literature, the desaturation events with comparison between low-flow nasal cannula and high-flow nasal cannula. So desaturation less than 90%. For low flow is 12 to 16 versus 0 to 1.5% for high flow population. And this was their proposed guidelines, again, including high flow somewhere between 30 to 70 liters per minute. And again, this goes hand in hand with topicalization. As you can see off on the right, some of my colleagues and mentors in my fellowship program actually proposed the utilization of high flow nasal oxygenation as their standard for topicalizing the airway for awake tracheal intubations. And they proposed, aside from sedation, glycopyrrolate to dry up secretions, they would get their patient into the room, again, hook the patient up to high flow, pre-oxygenate while you're assembling your monitors, and you can either nebulize or use the atomizer, and it coats the airway. So not just the nasopharynx, the oropharynx, but it further moves down the airway, which may or may not, depending on how you do your wake fiber optics, may take a step out of it. So some people pause right when they get supraglottic and inject additional 4% or whatever your local anesthetic is. This kind of negates that step. And this is just an example. I don't know why my fellowship program director felt the need to take a picture of himself, but this is, again, the basic setup. And then, the use of high flow and Thrive in this concept of the difficult airway. So oftentimes we think of things in terms of the anatomical difficult airway. And I think COVID in particular, and I think I mentioned this back in Chicago, really shed new light on this concept of physiologic difficult airway. The Society of Airway Management set forth a few parameters and guidelines based on 12 airway specialists across multiple specialties to combat potential difficulties and poor outcomes associated with physiologic difficult airway. And the two areas that they focused on was hypotension and hypoxemia. And what they proposed was that pre-oxygenation should be performed using high flow for at least 3 minutes or 8 vital capacity breaths. And the reason being is because desaturation events is the biggest factor for cardiopulmonary arrest. And anyone that's been involved in emergency airway management or intubated COVID patients, I think they would agree. And switching gears again, back to the anatomic difficult airway, and it's very tough or difficult to speak on airway management without mentioning at least some predictors of difficult airway management. This was the first and largest, and some of you might remember this, it published in 2013 in anesthesiology, but first and largest study looking at predictors for both, independent predictors for both difficult mask ventilation combined with difficult tracheal intubation. And as you can see, it's a relatively large cohort. They had data from over close to 177,000 patients over the course of 6 years, and they described difficult mask ventilation as a grade 3 or 4, and a difficult direct laryngoscopy as a grade 3 or 4, or greater than 4 attempts. And the incidence that they found through their data collection was that out of all these cases, there's only about 0.4% met the criteria for combined difficult mask ventilation and difficult tracheal intubation, which doesn't seem like much. It doesn't seem like much at all. But when you're dealing with patients' lives, family members, friends, and you're not dealing with statistics or numbers, that's relatively impactful. So I'm always thinking in the back of my mind, how can I help augment or mitigate this? And of course, some of these risk factors that they identified are now incorporated into our standard airway exams and preoperative guidelines. But one of the big and important papers that came out in anesthesiology in 2019 that kind of summarized all the data at that point in time and recommendations for managing these types of patients with difficult mask, difficult direct laryngoscopy, and it focused around prevention and planning was this article. And again, it was a review of the current guidelines, and what they suggested is, of course, pre-oxygenation should be applied to all patients prior to induction of anesthesia. Of course, we do that all the time, but pre-oxygenation and Thrive have been shown to delay the onset of hypoxemia, as I previously mentioned, and up to 70 liters per minute of flow has been shown to reduce CO2 and provide tolerance to apnea for prolonged periods, and this has since been supported by the 2022 American Society of Anesthesiologists guidelines for management of the difficult airway. And then moving on to surgical laryngoscopy, and when I initially gave a similar talk to a grand rounds Department of Otolaryngology at Thomas Jefferson University Hospital, and there was a lot of interest around this, and it sparked a lot of the conversation. But my experience using high flow, aside from using it for awake fiber optics, has been in the setting of ENT procedures. And you can use it for micro DL procedures. You can use it for laryngotracheal, assuming that you're not using the laser. And you can also use it for intermittent apnea or intubation. And there's been a lot of literature on the ENT side looking at this. But the basic setup again is get your patient into the rooms, have them immediately hooked up to Thrive, 30 to 40 liters per minute, spontaneously ventilating. You do a pre-induction timeout to discuss the airway plan. As soon as you induce anesthesia, patient goes apneic, you increase your flows to 70 liters per minute. Again, patients, I would say on average, tolerate this quite well. You can either provide a jaw thrust at that point in time and or hand the airway off to the ENT. In my experience, I hand the airway off to the otolaryngologist relatively soon. Reason being because more often than not, they're going to perform direct laryngoscopy. It's going to relieve any obstruction that might be present. The maintenance, as you can imagine, would be maintenance of anesthesia would be TIVA, and always the big question is how do you manage or record or document and keep track of CO2? And there's discussion around the use of transcutaneous CO2 monitoring, and I'll circle back on that in a moment. In the otolaryngology world, they're very curious about this, as I mentioned, and over the past few years, there's been a lot of research interest into it. For example, this article published in Laryngoscopy, which is one of the big otolaryngology journals back in 2022, looked at this concept of tubeless anesthesia. And they looked at data for 35 patients over 3 years presenting for direct laryngoscopy, endoscopic debridement of subglottic stenosis. And they compared the use of a supraglottic 10 French catheter, which is at low flows, versus Thrive. And there wasn't any laser use or balloon dilation for this that would interfere with oxygen flow. And they recorded the apnea times. And interestingly, they found that the apnea time for the low flow was actually better than the use of Thrive, so 34 versus 25 minutes. However, the low flow had multiple complications and required rescue maneuvers greater than 3.5 times, mostly related to laryngospasm. And they identified that BMI was the biggest contributor in their study population to desaturation events. And similarly, another group of ENTs took it a step further, and they published actually in the British Journal of Anesthesia, looking at the use of high flow or Thrive relative to tracheal intubation. And as you can imagine, they recorded lowest SpO2 over the course of 30 minutes. But for the sake of time, just looking at desaturation events over the course of 30 minutes. So it's at the top there. It's relatively similar. So not having a secure airway and having a secure airway, oxygenation relatively similar. But as you could take note right in the middle there, there was an increase based on their transcutaneous CO2 monitoring, Thrive or high flow versus endotracheal tube. And what they found was, what they concluded and what they proposed was that this randomized study shows high flow oxygenation may be as effective as tracheal intubation and oxygenation during laryngeal microsurgery. Nonetheless, incidents of desaturation and rescue intervention were more frequent for high flow nasal oxygen than for tracheal intubation. And equally as important as pre-oxygenation, oxygenation during procedures, I think it's very important to point out that it's very effective in extubating, particularly critically ill patients. And there's been multiple studies looking at this over the past several years, both in low-risk populations. I cited one that's relative to low-risk populations, but more recently in high-risk populations. And they collected data. This was completed in ICU setting, but data for 527 patients, 7 ICUs over 2 years. And the goal was to determine if high flow is superior to conventional modalities for preventing reintubation. And they defined, as you can see, low-risk populations, less than 65 BMI, less than 30, absent or moderate severe COPD and absence of heart failure. And they, in fact, found that the reduced risk of intubation within 72 hours with the use of high-flow nasal oxygen. Anecdotally, I think that Thrive works quite well for successful topicalization, as I mentioned. It increases patient satisfaction and tolerance. Patients tolerate this quite well. You could have sedation running. I typically do awake fiber optics with a low-dose remifentanil running. They'll be following commands, no desaturation events, and again, topicalization of the airway is, in my opinion, superior to traditional methods. Benefit the patient with partially obstructed airways, reducing the work of breathing and airway resistance, again, very key. And then CPAP for your high flow, from high flow appears to optimize airway patency and visualization of the anatomy. Now, I think there's a lot of future investigation, and there's been articles that have come out recently looking at more specifically CO2 clearance, and things are still relatively inconclusive, but I think we need to be selective in which patients we use, or which patients we use Thrive or high flow on, at least in the anesthetic application. I think and there's, as I mentioned, there's continued work on extubation outcomes, and there's data coming out now with regards to high-risk patients. There's this discussion around failure to thrive and what should be your cutoff, what should be your criteria for patients you should use it on and not use it on. And as I mentioned, CO2 clearance, it's a hot topic, and there's ongoing study into this as we speak. And that's all I have. Questions I think will come after, but if there's anything pressing, please let me know. Thank you.
Thank you so much, Dr. Grenda. Next, we'll be joined by Dr. Robert Molnar. Dr. Molnar is a board-certified anesthesiologist with 35 years of private practice. He has extensive training in cardiac anesthesia and pain management, and he's recently joined Rush University in Chicago as an associate professor of anesthesia. Dr. Molnar has also founded an airway device company that's making its way to the market this year, so congratulations. Today, he'll be speaking about this device journey and bringing airway devices to the market. So please join me in welcoming Dr. Molnar.
Thank you all. The journey through my eyes is probably the best way of stating what I'll be talking about. Anybody in here has had ideas that they would like to bring to market in airway management or some type of medical devices? Anybody ever had an idea and had an epiphany and said, wow, this would be something good? Any show of hands? Anybody? Yeah, there's a number of you in the room, and I think that's the start. And that was the start of my journey, and that was probably 15 years ago. So that was before I had hair. So I'm going to talk to you about my journey as it relates, and let's get started. So obviously I'll be talking about my journey, which entails bringing a product to market, in this particular case airway management. And so my views are through this lens, and so that's my disclaimer, disclosure, etc. At the same token, this is not a how-to guide, but I hope that it does give you some insight into even the thought process. Maybe it'll talk you into it, maybe it'll talk you out of it, or maybe it's just the ambivalence is the way to at least start. Some of the things I'll be covering is, I think it's very important to start with the concept of why do it. And there's a multitude of reasons of why doing it. It's a personal decision. And you'll have a lot of coaches on the sideline, but ultimately it's going to be you in the hot seat. What problem needs to be solving? Because ultimately you're talking about solving a problem in the marketplace. Now, this is not typically, obviously, a consumer item, so this is not going to be off the shelf. You're not selling it at Walgreens. This is going to the hospital services, maybe anesthesia, maybe paramedics, anybody in the ancillary service, maybe the military. We'll talk about how do you begin, and very importantly, having a business plan. I don't have a business degree. I have a business degree of common sense, knowing how money goes in and out, but obviously many of these things that I'm talking about, you will need some type of counseling. FDA concerns, obviously, when you're bringing a medical device to market, we'll talk about that. The manufacturing and production, who's going to manufacture it, how is it going to be done, how do you get started in trying to find that out. And then gathering a team, because certainly you're not going to be able to do this on your own. And let's continue. So we talked about this a little bit. Why do it? It's going to be a long pathway. My journey started with the idea about 15 years ago. I just came to market this year, and there's a lot of different reasons for that. People invent for a variety of different reasons, like we talked about: creative urge, fame and fortune, which some people may think that that's the end all. Desire to help others, certainly. Improving upon a product and making things better, maybe for what you want to use or somebody else uses. Your personal rewards may be something entirely different. So, most importantly, when you're coming and trying to bring a product to market, or even of the concept of trying to change things, is what problem are you trying to solve? And this is extremely important because you're setting up a business. Whether you know it or not, or whether you sell the idea, somebody is investing to sell this business, or is using the product or marketing the product to create money. And that money is used to obviously keep the company going and to fulfill the dream that you might have or a company has. And if you're not solving a problem for the individual user, the hospital organization, or cost basis, safety basis, etc., then nobody's going to buy your product. And so some of the things I'll be talking about will be interwoven into a fabric because it goes back and forth. Everything here has to be done in parallel, essentially. It can't be done in series. You can't come up with an idea and come to the very end, manufacture the product, and find out that nobody's going to want the product because the product costs 10 times as much as another product which solves the problem in a reasonable manner. So you have to think about this all through this journey. So what value proposition are you bringing to the practitioner, like we talked about? Are you improving safety? Are you improving outcomes? Are you improving all these things? Obviously, the more things that you can check off in the box, the better it is. But once again, what is validated? At this particular time, nothing is really validated. I put this slide in to show you the multiple pieces and how you're juggling the pieces at the same time. You can't start with one piece and not think about how the other pieces interact with the original piece. They all have to go together, and sometimes you remove a piece and you add a piece. So let's talk about things to consider. So before you begin, does it make business sense? And we'll go back and forth on this topic very much so. Even when you get to the final product, you still have to validate and say, is this the vision? Is this validate my business plan that I started with in the original concept? Most importantly as well is, what is the size of the market? If it's a very, very big market, you're obviously going to have more competitors, and at the same token, you'll have more dollars available to be spent potentially on your product. If the market is very small, that means that you're a niche product, and that makes it a little more difficult, at least from my point of view, into who is it exactly you're going to be selling, and it's going to be a small audience. Does the product make sense? And this takes an extraordinary amount of time. I can't tell you how much time it can take, but I think the first thing is, when you understand a topic, and the book previously written some years back, 10,000 hours, is probably a good start. So you identified the hurdles. Now you have to say, you got a great idea. I have this idea. It's the next best thing to sliced bread. Now you got to see, well, does anybody else have this idea? Is it already produced in another country? Is this patent already exist? You're certainly most likely bringing a medical product. You're going to need some intellectual property. If you, by that meaning patents. If you don't, what happens is that somebody certainly that if you validate the process and validate that there is a market for it, somebody's going to copycat you, and many of those people are much bigger than you are. So you're going to need some intellectual property. In obtaining this, you're going to need some legal counsel. There are a few doctors that I've known, I've run across in the field, that actually wrote their own patents. And so I take my hats off to them. I was not one of them. Once you have this and you're testing your validation, you need to use first principle thinking. I know Elon Musk talks about this, but it was really Aristotle, in trying to validate the process. And basically what this is first principle thinking removes all assumptions. The most important part of solving your problem is defining it. And what that means is basically, what are you absolutely sure of? Strip everything down to its very core. Not what you think, not what you believe, but what is self-evident in the process. We're all breathing here. We're all ventilating. We're all having respiration. That's an evident process. So you start with that premise and you work forward. The inverse process of thinking might help as well, meaning if you did the opposite or something that's counterintuitive, it shouldn't work, or potentially not work, but it will give you some type of insight as well as the process. You're going to need some brainstorming with other people and peers. Obviously, as anesthesiologists and physicians, you can run across a multitude of people, and you're going to get a multitude of ideas, and some positive, some negative, but that's okay. You need to have a outlook of being an impartial judge. And in that impartial judge, you need to provide data or provide common reasoning as to why this will all work. Making a crude model for testing is important. You can compare it to other things that are on the market. Mannequin and cadaver model of testing in my particular case, as well as putting it in your own self or myself or other people that were willing to do it. And then if you have trials and studies, which is obviously important. Creating the business plan is extremely important. Who will create this business plan? Will it be profitable? We talked about. This goes in and out and is a continued woven into the fabric that we're talking about. Who's going to validate it? How will it be executed? Will the product be patented or licensed? And then when you're coming to market with all this and you race to the finish line, do you have a patent? Many of these patents take 4 to 5 years to be reviewed and to be patented. Hopefully that you do get the patent. And whatever you put in at the patent office will, for the most part, in my experience, will always be refused. And those are the experiences I have, but many as well entrepreneurs have the same experiences. So if you put in that you have a chair here with 4 legs, the patent office is going to say, we have a horse here that's been walking the earth for thousands of years, and that's not novel. And you have to say and try to describe to the patent office that a chair is something you sit in, a horse you sit in, but a horse you feed and you give water to, and it's a living creature, and a chair is not. And so that gives you a little bit of insight as to what you're dealing with. Who will form the company? What are you planning with the ideas? That can obviously always change over time. And who is your target audience, obviously? You're dealing with a medical device, so you're talking about FDA considerations. Basic considerations, FDA Class 1, 2, and 3. Class 1 would be like a Goodell or Berman airway, oral airway. Class 2 would be similar to an endotracheal tube or a fiber optic bronchoscope. Class 3 would be like a pacemaker. 510K relates to a shortcut to the pathway of trying to bring a device to market or through the FDA. What that means is basically, with FDA Class 1, you just have to have your testing, your validation, your quality controls. You have to have the documentation, but you don't get a approval necessarily from the FDA. Anything beyond that, you certainly do. 510K means that you're similar to a product that's already on the market. And you go to the FDA and you say, for instance, let's say you have an endotracheal tube. And you go to them and say, I have an endotracheal tube, but there's many endotracheal tubes on the market, and this one that I'm going to compare to is made from the similar substance that mine is, or the same substance. Mine is just a little softer at the tip, or whatever it may be. The balloon is the same type, etc. And you put those in a document and you send it to the FDA. The FDA reviews it and says, yeah, that's reasonable. You don't need any further testing because obviously the plastics they're using is the same plastics that you're using, and so they agree and they give you a 510K certificate. So for this, obviously, in this process, you're going to need an FDA consultant. I don't know of anybody who's gone down this pathway that hasn't had an FDA consultant, and it's important that this consultant works with you very handily and closely, because many of your ideas may change over time. You started with an idea. Remember, I told you the fabric continually changes. And as you're going through the process, you might come up with an idea and you say, wow, I had this initial idea, but this idea that I have now that I've gone through this is a little better. Well, once again, you need to rework this. Go back to the business plan. Go back to the cost basis. How big is this market, etc. Now you got it to this, obviously, point, and now you're going to need expertise in making the product. And you're going to go to multiple manufacturers, maybe to that, in this country or overseas. Obviously, if you're making it in this country, the benefits is obviously to the country itself, and the national pride, or whatever it may be. But beyond that, if you make it in this country, it's typically local. They speak the same language. You can converse with them. You understand what they're saying. They understand the culture. Many times you deal in some countries and they say no, they mean yes. And when they say yes, they mean no. And you'll see them when you're on video chat and they'll say no, and vice versa. So it's important to have some type of dialogue. Having a company that's close by always is a positive, but you may not have that benefit. Obviously, where will it be made as well? Transportation, it will add to the cost. Quality and control standards. Who's going to maintain these quality and control standards? Has this company done it before? Just because a company makes something that you can put into a device, you're now talking about a medical device. So when you see on Amazon and you see a camera that works very nice, and it's like a borescope, etc., typically those aren't made in a manufacturing standard that needs to be upheld in a medical device. And what I mean by that is that, God forbid, you have a recall number. Are they even tracking what parts are going in? How the device is being shipped? How is it being manufactured? What type of room is it being manufactured in? So there has to be quality control standards. So just because you see something that's validated in the consumer end doesn't mean that it's going to be as easy as you think to bring it to market. You're going to need certification, ISO regulations. What that means is that there are standards of regulations in manufacturing, and you're going to be held to those standards when dealing with a medical device. You're going to need sensitivity and toxicity testing, and then obviously if you have electronics involved, enjoy the ride. You're going to gather the team. You're going to need just a multitude of people, business planner, attorneys, multiple attorneys, general and counsel, patent draftsmen, 3D engineers, consultants, accountants, manufacturers, quality consultants, marketers, FDA consultants. Now, many of these people can wear the same hat. So you might be able to wear 2 or 3 of these hats. If you have a business degree, maybe you can wear 4 or 5 of these hats. I'm not saying they're individual people necessarily, but these are things that need to be done. Obviously, when you get into you've done your crude prototyping, maybe you're doing your fabricating, you did 3D molds. Some of these are 3D molds. I can tell you that for the devices that I brought to market, the number is probably 4 to 5 times that. And each one of those costs money. They're fabricated, either 3D printed, etc. The entire process and prototyping models need to be in parallel, like we talked about, not in series, because now you've got this great product. You've tested it. You looked at it. It's your baby. And then now that you look at it, now you need to go back and look at what does this relate to your business plan? Did something change? You made it here, and now you have a manufacturing process, etc., but it costs 4 times the cost of what your original idea was. Does that disrupt your business plan? Everything has to be interwoven. You need to revalidate, validate, recheck, and check. And then, along the way, you're going to gather some people that are going to be interested in your idea. They may join your company, and they might be interested enough to try to test the device.
Get down, there you go. Gotta push through it. There you go. Good. Breathe through it, go through a little. You just have to push the device further because you're in. Oh, there you are. Okay. All right, you go. Breathe. There's your vocal cord.
It's easy. It's easy for me to say to breathe.
You did very good. Now let me get the. What was your thing? The device. Push the camera a little bit. And smile, Brad. You did. Much easier to lean over. Something you want to say?
So that was Brad. He's a casualty along the way, so he helped join the company. But anyways, as he mentioned, much easier than Lino. That means there was other people along the way. I've done this dozens of times, as well as other people. So friends and family can help you along the way. I put this in here because we talked about patents and protecting the idea. And look at how far along we've come in this journey. We talked about that you have the device. It's right there. It's ready to be manufactured. You validated the idea. And you get to this point and you don't have a patent. That's 4 years later. That's a problem. Or you do have a patent and you say, hooray! Now you can expedite patents in the patent office. Costs more money, but you can shortcut that process. But typical patents are about 3 to 5 years. You brought the products to life, etc. Here it is, or whatever it is that you're doing. Going back into the when you brought this product to market, some of the things that is important when you're trying to deal with manufacturing is this. If you're making a product that's already similar or has the same construction process as somebody else, then you find maybe a OEM manufacturer or manufacturer that makes items for off the shelf or for individual people or companies, that they understand the process. They understand how to do it, they've done it, and they validate it. That's the shortcut, because now that company understands what you're doing, etc. And especially if they don't speak English well. Going down the second route, or the other rabbit hole, as somebody would say, is the harder process, meaning that you're trying to educate them as to how it is to be put together and how it's to be manufactured and what type of materials it's going to be. That's a much more difficult pathway, because now you're going to bring a team together of engineers, you're going to bring a team together of people who may or may not have done that in that particular fashion, and now you have to educate that manufacturer as to how to do that. And that's going to cost a lot more money. So the simplest way of doing this is to try to blend into the mainstream, meaning finding manufacturers that have already done it, have done it, it's a similar product. They make endotracheal tubes. In the example I gave you, you're making an endotracheal tube, you have a patent that maybe has something that provides some benefit to that endotracheal tube, to that end user. And what that does is provide that manufacturer the green light. He understands it, or she understands it, and how to manufacture it. It's the same process, it's just the mold is different, the injection process is different, but the end product is easy for them to conceptualize. That's the best way, if you can get to that process. But not all ideas are thought in that particular manner and can be conceived in that manner or produced in that manner. The important points when you're dealing with these companies are, can you trust them? What is the cost? You revalidated everything along the way. You have your product. You're happy with the product, etc. You have your team. And now you build your brand. And that's a talk in itself. And I got educated along the way, because obviously when you're building the brand, you're going up with other people that are in the space that you're in, most likely, and you need to separate yourself from them in some particular manner. Obviously we know Apple, Starbucks, and Nike didn't get to where they are relying on their products alone. They have incredible brand appeal. The most important thing about your brand is that you promise to the customer through visual and written cues what your brand represents in business, and essentially you're developing that brand and trust with that customer. So everything that you do, every way that you represent your device or product represents your brand. Basically, this is my journey, and it continues along the way. And I thank everybody for their time and attention.
Thank you so much, Dr. Molnar. We're going to begin the Q&A session at this point. So if you have any questions, please feel free to come up to the microphone. It looks like we just have the one right here. Okay, thank you. Well, while we get that microphone coming up, thank you, all of you, for such wonderful lectures to start off this series. As far as Dr. Molnar, with the journey that you've gone through, I think we all have been in situations where we've been in, especially as we're talking about airways, that we've been in challenging spots going, I wish I had something like this. But of course, no one ever really wants to go on the journey that you've just gone through to do all of this. As far as marketing and the costs, the patents, all these things that take not only the time, but the actual cost. I know working at an institution, academic hospital, a lot of our surgeons or people who have developed products end up requiring the patents, all the costs get taken by the hospital. So they put out all of that, but then of course the hospital then owns it. Have you, being in private practice previously and going through this journey, whether you would recommend or is there a benefit? Have you found that you were funding this all on your own or going through corporations that were kind of helping with this?
So when I went on this journey, I knew that I needed a lot of money, and I needed a lot of time, and I needed a lot of help. And so I went to a multitude of different people. And early on, I went on to, without giving the ideas away, obviously, because once again, we talked about the fabric in which you have your idea, you have honed in on it. You might have already done some testing with Brad or other people, and you're validating your idea. But you can't tell them what the idea is, and yet you need more money, and you need quite a bit of money. And so I tested that water, and that water obviously wasn't for me. And so the other thing is then you start to go to friends and family, you start to talk to people who might be other anesthesiologists or other practitioners, and present the idea to them. And however you get there, at the end, all the money is green, and you just need the money to move forward. At the same token, obviously, if you're part of an institution, that problem goes away. They'll license it, they'll do whatever it is to it, and whatever agreement that you have with that institution will proceed forward. So the institution will own the intellectual property, and whatever percentage is previously agreed on in your contractual terms is how you move forward.
Thank you.
Wonderful question. So with the nasal cannula in, so if you're going to go through the nose for the wake fiber optic, you can transition it down to the mouth. If you're going to go through the mouth, as you can see in the picture, they actually use the nebulizer, but I prefer using the atomizer, and I can control how much is going in and where it's going. Yeah, it's relatively straightforward. I see. No, it's completely separate. That is correct. Yep.
So in that way, there's no nasal component. You're not anesthetizing any part of the nasal pharynx. It's just the oropharynx. And
but vice versa. If you were planning on going through the nose, you could easily just transition the nasal cannula down to the mouth. I know it seems a little bit unconventional, but it actually does work relatively well.
Wonderful. And Dr. Molnar, as far as with companies that already have products, for instance, in pediatrics, a lot of times we have challenging sizing, and a lot of us will say, I wish we just had this size. Would you say that there is is it best to just go to the actual manufacturer and say, my personal opinion is I don't want to go through this whole journey, I just need this, and can you just create this?
You can, but you get diluted very, very quickly. And the reason for that is that you have not validated everything. And the validation, the most important validation, when you go to that manufacturer or company that may be in that space, is do you have sales? It's kind of like Shark Tank. Do you have sales? And so when, obviously when they go up there in Shark Tank, and we all seen it, I'm sure, and they say, well, I don't have sales, I'm coming to market, etc. They look at you different as opposed to that, yeah, we have sales and we have $7 million. And everybody's eyes light up. So it's a matter of what ambiance you control in the room, and do you have sales? Is it already, and the sales are just basically validating that people buy into your idea, and that idea works, and that you have repeat sales. So if you have that, I think then obviously you're king or queen, and you're in the room and you control. The other way, obviously, it gets diluted very, very quickly, and that's a pathway I did not
wish to choose.
Thank you. Oh, yes, please.
This question goes out to Dr. Grenda. Thank you for all that information you presented. My question is this, two things. Number one, Fisher Paykel, that was a company I believe that was advertised. They're a New Zealand company, is that correct?
I honestly don't know.
Okay.
Yeah.
But was this founded in New Zealand, founded in England?
The concept of Thrive?
Yes.
Not necessarily. No. I think I presented on so the OptiFlow is just the system that we have in my current institution that's utilized in the ICUs. It's the one I'm more familiar with. Yeah, that's just I just wanted to present the parts. Yeah,
That's very cool. And then the second question, I'm running the numbers in my head. 70 liters a minute.
70 liters a minute.
I mean, you can burn through E cylinders, H cylinders, and nothing flat. Is that liquid oxygen that your institution has to maintain that? And what are the costs?
Great question. So it hooks in, actually, there's an adapter that goes into the central hospital supply, so it's not necessarily hooked or connected to an E-cylinder. With regards to cost, the system is actually relatively cheap as well. Again, I just know the data for the OptiFlow because that's the one I've been arranged to utilize in our institution. The actual standalone system is probably around along the lines of like $1,000, and then the connection, so the nasal cannula, the tubing, the humidification canister, around $75. Which, I mean, of course, adds up, but at least with regards to patient care, I mean, it's dollars and cents, I would imagine.
That's great.
Yeah.
Thank you.
Yeah, sure.
On that same note with the Thrive, and in pediatrics, I'm sure you both can kind of comment on this. I know in pediatrics, a lot of times when we do laryngoscopies, what I'm hearing from my adult colleagues is completely different. They paralyze for adults to do these bronchoscopies. They do apneic oxygenation, and in peds, we keep them spontaneously breathing most of the time. So obviously, it's a completely different subset, partly because our patients in the peds population will desaturate so quickly. I don't know if you can comment. Do you use any kind of Thrive? I know a lot of times we're just masking and then pulling back and forth and doing insufflation or other techniques for oxygenation in peds.
We always use some sort of supplementary oxygen system. We do use increasingly more commonly Thrive or the OptiFlow, specifically the OptiFlow high flow nasal cannula. Does it make a difference compared to low flow? Maybe. With low flow, we can provide the same because they are, small, and you can go up to 20 liters on your low flow. For an infant, that's enough. But the humidification helps. The ENTs don't like a desiccated mucosa. So they are actually proponents of Thrive. But there are other ways to administer supplementary oxygen, one being the side port of the Parsons and the Lindholm laryngoscopes, or endotracheal tube just in the corner of the mouth. So on.
And I would say in your practice overall for adults, are you, like, if you had 5 patients in a lineup for bronchoscopies, rigid bronchs for that day, are you using Thrive on all of them? Would you say once in a while based on BMI, or how are you kind of picking your patients for this?
Yeah, in my experience, I would say BMI 33. Again, there's a lot of variability with that. It's usually my cutoff. I've had Thrive, so I always bring up the question about failure to Thrive, and I think there's a lot of room for research there. I've had it fail, but again, it's a slow process. It's not immediate, in my opinion, I would use it more often than not. Because mostly the surgeons appreciate it because they don't have a big object to work around in the airway, and if it's going to be a relatively quick procedure, the patients, in my opinion, again, benefit from TIVA and the medications. I think it's a faster recovery, so on and so forth. It's better tolerated.
Have either of you, I think this, in pediatrics, we get more concerned about the hyperoxia, and NICU babies, the NICU gets very cautious about our oxygen levels for this. Do you see in the ICU population or any of these patients, I'm not sure how long you put a patient on Thrive, what like an average in ICU would be versus a short-term procedure, and monitoring the oxygen and outcomes and things?
Yeah. So typically in the ICU, they have a blender. So there is, so it's still hooked to the hospital, air and oxygen supply. In the operating room, you're just titrating oxygen. So you're giving 70 liters of oxygen. Again, in my experience, I would say on average, particularly for the ENT procedures, I would say most of my patients average somewhere between 30 and 40 minutes of apnea time if I select appropriately. Again, I emphasize with the surgeons to move quick, and they understand the risks associated with it, obviously. But if it's a quick biopsy, patients you don't have to intubate. The patients tolerate it quite well. Yeah.
I had a question for Dr. Hunyadi. Is that how you say your name? Very good. Okay. You were talking about an airway management team, I believe, that anesthesia is part of. Can you just talk a little bit about that team? Who's on that team? Do they go to the ICU? How do they work with the intensivist? And how do you designate a person to be on that team every day? Where does that staff come from?
So in our institution, it's essentially always the board runner or the charge anesthesiologist of the day. In our institution, the charge does not staff a room. In addition to that, we have a backup person. We now have a person in the PACU all day, and that person also carries a beeper and a phone. So this is a redundancy in our system. So whenever anesthesia is called into an airway management scenario, then both of them, both of them gets the notification, and both of them try to respond, and one of them usually will. We get the notification over the phone, overhead, and or on beeper as well. So we get called to every single intubation if it's a relatively elective, or we have a longer lead time, then the ICU would call the board runner and say that, look, we need to re-intubate this child in this room. Timeline would be about 30 minutes. Can you please be there? That's obviously different from a crisis scenario where we have to run responding to an overhead page. So it depends on the situation. If it's an elective airway, the ICU. Hello? And not a difficult airway, then the ICU fellow gets the first dab under the coaching of the anesthesiologist.
And I saw the time frame for the critical airway team. I know this has been a huge thing since Johns Hopkins started this. And at different institutions that I have worked at, there's been the same problem where, especially July, August, when we start the new year, calling the incorrect team, or some of us take call from home and there's not a true pathway, or there's a pathway and no one's following it. A lot of times we get called from the peds residents on the floor, urgent versus emergent, ER kind of situations. Was there a part of the structure other than having the key components of the team members? Who was it that kind of aligned everything to make sure that is streamlined? Was that making sure it was the page was out going to the correct team and so forth?
So that was a very, very long road. And the key is to have the multidisciplinary airway committee with a clear lead person who is very familiar with the institution's setups, as well as the training system, to make sure that the calls are appropriately dispatched. It remains a problem that ENT is still not in-house, actually. So that remains something we need to solve.
And have either of you at your institutions, again, I think every place has a different role. We are able to, because we have residents in-house or anesthetists in-house versus ER colleagues or even adult colleagues versus peds. Every institution is different. Do you guys have setups at your hospitals for difficult airways that get streamlined?
Yeah, so at least well, I should say it depends on setting. So when I'm at the cancer hospital, it is attending. There's the residents are usually in the rooms. There's no resident assigned to airways, but we get called for every airway. Not necessarily rapid response, but every airway. So critical or not, in the ICU or not, we present for the airway. Similarly, at the Temple Main. We respond to every airway as well. However, there's residents associated with it. We have poem fellows, and sometimes they'll ask to do the airway. And if we feel comfortable with it, then it's fine. But usually when we're getting called, it's a little bit of an emergent situation.
And do you have a similar setup where the pager goes off activated and you respond, no ENT or anyone else?
Right, so there's different codes for the airways, which I find beneficial. So there's critical airway, which, typically for that, the surgery team and ENT show up, so both show up in addition to anesthesia. And then there's just emergency airway or anesthesia stat, which is just the anesthesia team showing up. Yeah.
And I have to say, Dr. Hyundai, that was one of the best parts. I think from anesthesia standpoint, we all understand oxygenation versus ventilation, difficult versus critical airway maskability. I don't think any of our surgical and non-surgical colleagues understand those. And I think that's one of the other parts is we get a call for a difficult airway, and it might not be a congenital airway or someone that was marked as difficult. It's just that someone else, from the pulmonology team couldn't do it or things. So I thank you for highlighting that. I think that's one of the biggest things for the team responses that needs to be written down. As far as the foreign body airways, depending on what your practice is, I know in our system we have a main pediatric hospital, but we have a lot of regional hospitals that do adults in a mixed practice. And sometimes these facilities will do these foreign bodies. I don't know how Seattle Children's is or in other facilities. Do you come across those are patients that you should have transferred to a main pediatric hospital, or depending on the scenario, because some of these foreign bodies are like the peanut kids really are reactive and they should not be transported? Do you guys have like an age cutoff, or do any of the regional hospitals within Seattle take care of those children?
I only work on the Seattle Children's campus. We do have a city hospital. The trauma hospital is a city hospital, the Harborview Medical Center. I do not have any data whether any airway foreign bodies would go to Harborview. I do not think so. I think all pediatric cases get brought to Seattle Children's, which is just a mile away from our adult campus. And I would say with no traffic or, with the red lights on, maybe 15 minutes away from downtown.
Have any of you had situations, foreign bodies included, or situations, and I think in PEDS world, we have a lot of patients who don't have IVs in these difficult airway situations, and they tell you not to put an IV, and you kind of get into these parts where you bite the bullet one way or the other, and you may or may not have chosen correctly. And in adults the same way, you might have chosen to do apneic oxygenation. Have any of you had a situation that has now changed your management with your care for these airway bronchoscopies, or situations that you've decided that no matter what, I'm always doing it this way, or I have changed my practice that this was not the best way?
I haven't had a case where I did not put an IV in. I had many cases where the ED chose not to put an IV in for comfort or for thinking that the child will be masked down anyways. I think in this scenario, I do want the IV in place for rapid resuscitation.
Not necessarily with an IV, but there was one case that sticks out in my mind early on when I was just learning the nuances of using high flow in the operating room, that I chose not to give paralytic. And since that point in time, patient laryngospasm and so on and so forth, as soon as the ENT instrumented the airway, since that point in time, I perform an RSI every time.
Very different from my practice.
Very different. Very different. Yes.
Yes, completely
yes.
different scenario.
Yeah.
And a little on topic, off topic, when I did a difficult airway lecture in remote locations, there were a lot of studies coming out about awake fiber optics kind of being a thing of the past now, especially in teaching institutions with all the video laryngoscopies. When we look at pediatric airways, do you find that you're going to video laryngoscopy more quickly like the adults are as well? And do you feel that now with Thrive that maybe fiber optics are kind of coming back because you can do these awake intubations, or are you using Thrive with your video laryngoscopies?
That's a great question. I have used Thrive with video laryngoscopy, and I think it's very useful. Even if you're planning on mask ventilating or intubating the patient, it still works very well as a pre-oxygenation modality. I'm not saying it's the only thing, but it certainly works well. I mean, if I have it available, I will. Any case, as soon as I get the patient in the room, Thrive, and you're pre-oxygenating while the monitors are going on. You can take your time, and it'll the added benefit is that it may just give you another minute or so, depending on the situation and the case that you're doing.
The invent of video laryngoscopy definitely put less emphasis on fiber optic intubation, and there is some data from the PDIR that the success rate might be similar in terms of and the two can be actually combined very nicely especially for very, very difficult airways. In terms of awake intubation, it still has a role even in pediatrics. Not just in adolescents, but in younger kids, especially in neonates as well. And somehow it's not in the mindset of people that you could do an awake intubation with a video laryngoscope, mainly because it's often thought that, and it's true, that a nasal intubation is better tolerable than an oral. And also it's just not in, until you try it several times, it's not in your hands to do awake laryngoscopies.
Can I chime in just for a
Please,
second? First,
please.
from my point of view, I think the problem, or that what you say or what everybody says is true, in the sense that obviously the video laryngoscope and Dr. Jack Pacey, who invented it a number of years ago, changed the market in the sense that the most difficult intubations were now being able to be done with a video laryngoscope. But the catch-22 is now that people that were trained in bronchoscopy and had good experiences and have good knowledge base on that, those are few and far between nowadays. In residency training programs and in people even coming out, in my opinion, and that's the catch-22. The video laryngoscope solved probably 95% of those problems. But the 5% still needs to be solved. And now when you look at the algorithms from, many society, DAS or the ASA, et cetera, wherever you want to go, they always entail a bronchoscope. But now where's the expertise on the other end of the camera? Mm-hmm. That's the part that's failed now. And that's the problem that needs to be answered, I think, going forward.
Agree.
I honestly feel that, I can manage most airways, even difficult airway pathology, tumors and things like that, with a video laryngoscope, no doubt about it. But there's still situations that I find myself in. Either I have to do a combined approach, so fiber optic with video laryngoscopy. I just did it last week for a supraglottic tumor that the patient was going for a total laryngectomy, and I mean we were able to secure an airway without having to do an awake trach on the patient, which has implications and it can be very traumatic. So I think a combined approach and but I do feel very comfortable that with managing most airways with video laryngoscopy, without a doubt.
In my population, fiber optic bronchoscope will never go away. since we do see congenital anomalies where there's no mouth opening.
Agree. And I think the largest problem I've seen being in private practice versus academic practice, and a lot of these wonderful technologies are great, but you need extra hands. So the combined technique, if you're in private practice, as you can, Dr. Molnar, express as well, my first job was no one on call with you. You were no anesthetists, no residents, it was just you. And so unless you had ENT or someone else who was proficient in those equipment, doing a combined technique was not really feasible. So, and Dr. Molnar, one last question for me, unless we have other questions from the audience. Going through that journey, 15 years in and out, would you do it again?
That's a very good question. So I would do it again, but the real question is why I did it in the first place. And so the short answer is this. I had the idea and the concept 15 years ago, and I wouldn't have been upset with the company or the person that came out with it if I didn't proceed on this journey. But I would have been upset with myself that I didn't have the gumption or the confidence to say, I can do this and I have the concept and the idea, why not me? And that was the part that when I grappled with, that I came to, and that was the reason why I had to proceed.
Any further questions? All right, well, thank you everyone for your questions, and we're at the time we're going to conclude. I think we get a couple extra minutes here. Please join me in thanking Dr. Agnes Hunyadi, Dr. Dane Grenda, and Dr. Robert Molnar for their time and their lectures. And as you can see on the table, as well as in the little cards that you have, when you go to fill out your surveys, there's surveys to answer some of the questions and feedback for their lectures, if you could fill that out as well. And also remember, as you go out to get coffee in the break area, to visit the exhibitors. Okay, thank you. And we will start back up at 10:30 with session 2.